Hello everyone, welcome back to my channel, that is Obstetrics and Gynaecology Simplified. Today we will be discussing about Hyperemesis gravidarum. Okay, we will discuss, I will tell you what is the normal frequency of nausea and vomiting that is normal in pregnancy and what causes Hyperemesis gravidarum. Okay, so what is Hyperemesis gravidarum? Hyperemesis means constant more number of vomiting. Okay, so if the frequency of nausea or vomiting in pregnancy in early trimester it increases such that the daily activities or the normal physical activities, the social activities is affected, the daily routine is affected, okay, that cause an individual not to wake up and to do the regular things. Okay, so that causes disturbance in the regular or routine life, and that is the hyperemesis gravidarum. Okay, in normal pregnancy, in physiologically also there is some amount of nausea and vomiting. Okay, so we have to know what is the definition of hyperemesis gravidarum, what is the criteria that we are telling that all these criteria must be fulfilled so that we will say that this is a critically ill patient, this patient is critically ill and she needs admission, or we can if the like the symptoms or signs are not that much severe, we can just treat her as an OPD patient. Okay, so we have to know that in which case we have to admit, in which case we have to do the OPD management. Okay, how to diagnose the hyperemesis gravidarum and what is the diagnostic criteria of hyperemesis gravidarum. So let's start. Okay, so according to the Foxy 2024, there are 4 criteria. Okay, so that we can say that this patient to be diagnosed as hyperemesis gravidarum, but all the criteria that are mentioned should be present. Okay, all the 4 criteria should be present. So the diagnosis, what is the diagnosis? According to Foxy 2024, nausea and vomiting of pregnancy is the new term for hyperemesis gravidarum. Okay, that is nausea vomiting of pregnancy or NVP. Okay, and then if the nausea and vomiting is present, it may be only nausea, it may be only vomiting, nausea plus minus vomiting. I have written here nausea plus minus vomiting. It starts around 5 to 6 weeks. Okay, so that is the early first trimester when the beta HCG peaks. Okay, it starts to peak and then the symptoms arrive. So that is 5 to 6 weeks. Starting from 5 to 6 weeks, peak is around 9 to 12 weeks. Okay, and then it resolves around 16 to 20 weeks. So 90% of the hyperemesis gravidarum it resolves within 20 weeks because the beta HCG it plateaus. Okay, so the vomiting or the nausea it stops. So that is, it resolves in around 90% of the patients. So what is the normal incidence of the hyperemesis gravidarum? Almost more than 50%. Okay, 50% of the like ladies or the pregnant women, they experience hyperemesis gravidarum. Okay, that is 50 to 80%. The incidence is 50 to 80%. So we have to know, we have to diagnose, we must know how to diagnose hyperemesis gravidarum and how to treat the patient. Okay, then hyperemesis gravidarum. So what is the 4 criteria? That all the 4 criteria must be present. First is persistent vomiting. Okay, so persistent vomiting, how does it happens? Persistent vomiting, weight loss, ketonuria. Okay, these are the criteria. So more than 3 episodes. Okay, more than equal to, not equal to, actually more than 3 episodes, that is 4 or more. So more than 3 episodes, more than 3 episodes per day in 24 hours. If there is more than 3 episodes, so that means we got the first criteria, that is persistent vomiting. And weight loss, what is weight loss? That is 5% of the pre-pregnancy or more than 3 kg loss. Okay, weight loss should be more than 5% of the pre-pregnancy weight or more than 3 kg weight loss if it is present, okay, due to dehydration. And ketonuria is present, and dehydration plus electrolyte imbalance is present. Okay, so these 4 criteria must be present so that we term as hyperemesis gravidarum. All the 4 criteria must be present. And what is the incidence? 0.3 to 3%. Okay, then coming to the, see, all 4 criteria are required. Okay, coming to the scoring system. Okay, we have to know the score which we use to classify the severity of the hyperemesis gravidarum. Okay, so what is the severity? Like, if what is the score? The PYQ score. See, the definition is pregnancy unique quantification of emesis. Okay, that is PUQE, PYQ 24 score. That is pregnancy unique quantification of emesis score. So that this is a validated index of the nausea and vomiting of the pregnancy or hyperemesis gravidarum. So this score is validated. Okay, and we see over the last 24 hours. Okay, we have to question. There is a questionnaire. Okay, the PYQ score, it has a questionnaire, how much time the patient has vomited. Okay, so according to that we have to calculate the score and then we have to score it. So we have to sum all the points, and the severity bands are mild. So in mild the score is less than equal to 6, in moderate it is 7 to 12, and in severe, if the score is more than equal to 13, then it is more severe. Okay, then what are the risk factors? The risk factors according to Foxy 2024, there are 3 risk factors. Okay, first is demographic risk factors, then the obstetric risk factors, and then the personal or family history. Okay, the family risk factors. So first, coming to the demographic risk factors, age. So young age, nulliparous. Okay, in that case, in low socioeconomic status also, there is more risk of the hyperemesis. Young age, nulliparity, low socioeconomic status, Asian or black ethnicity, and extremes of BMI. Okay, so we have to remember the risk factors, the demographic risk factors of the hyperemesis gravidarum. And what are the obstetric risk factors? Where the beta-SCG is more, we have discussed, where the beta-SCG is more, that means there is more chances of hyperemesis, more chances of nausea and vomiting. So in multiple pregnancy, where the quantitative beta-SCG is higher, in molar pregnancy also, history of thyroid and parathyroid dysfunction, in hypothyroidism, in hyperthyroidism, in hyperparathyroidism. Okay, in these cases also there will be more nausea and vomiting. Okay, and also in type 1 diabetes mellitus, that is autoimmune. Okay, then coming to the personal or family risk factors. So the trace element deficiencies. Okay, then first degree family history of, if the first degree relative is having the history of hyperemesis gravidarum in her pregnancy, then this is also a risk factor, or having motion sickness or migraine, and past psychiatric or mood disorder is also a risk factor. Understood? So there are 3 risk factors. What? First is demographic, second is obstetric, and third is personal. So in demographic we have learned that in young age, in nulliparous women, okay, and then low socioeconomic status, Asian or black ethnicity, and extremes of BMI. Okay, in obstetric factors, multiple pregnancy, molar pregnancy, okay, history of thyroid and parathyroid dysfunction, type 1 diabetes, these are the risk factors. And then in familial trace element deficiency, when the first degree family is having the history of hyperemesis gravidarum, or motion sickness or migraine is present, or any psychiatric or mood disorders if the patient is having. Okay, so these are the risk factors we need to know that causes hyperemesis gravidarum. And then coming to the management. So management, so we know now the PYQ score, how to calculate the PYQ score. So On that basis, we will decide if the patient is in the category of mild, moderate or severe. According to that, we will have the management. So, first in the mild case where the PYQ score is less than 7, that means less than equal to 6. If the score is less than equal to 6 or less than 7, then we have to do outpatient management. That is, score is less than 7, then OPD basis. Management is on OPD basis, that is conservative management. Okay, here we have to tell the patient that patient needs to take frequent small meals, dry, bland, protein rich diet. Okay, then avoid spicy food. Or any order food, like if the smell of the food is more, okay, like more smelly, more odorous foods, she has to avoid. Okay, then the most important, we have to stop iron, because iron tablets we have to stop, otherwise in vomiting the iron itself will be excreted out, so there is no use of taking the tablets. Okay, then third, we have to start pyridoxine 10 to 25 milligram per oral 8 hourly. Maximum how much we can give? 100 milligram per day. And this is the first line. Okay. Then extended release pyridoxine 10 milligram plus doxylamine 10 milligram. Okay, is preferred. 40 milligram. Okay, this one is doxylamine 40 milligram and pyridoxine 10 milligram is preferred in case of mild cases. So now we know what is the management in mild cases. Then in moderate cases, what we need to do, moderate means the score is 7 to 12. Here we have to do the OPD basis management, plus we have to add antiemetics. Okay, here we have to continue pyridoxine plus doxylamine. Okay, then add H1 antihistaminics. Okay, like promethazine. Okay, promethazine, cyclizine, cinnarizine, and dimenhydrinate. Okay, these all can be added. Okay, that is H1 antihistaminics we can add with doxylamine and pyridoxine. Okay, then add phenothiazines. So first is H1 antihistaminics and then phenothiazines. Phenothiazines we can give prochlorperazine 5 to 10 milligram 8 hourly, or chlorpromazine prochlorperazine or chlorpromazine. Okay, then metoclopramide, 5 to 10 milligram TDS. And what is the maximum dose? Maximum is 30 milligram per day. Okay, so that is the 30 milligram per day metoclopramide also we can give, and we have to stop if extrapyramidal side effects appears. Okay, stop if extrapyramidal side effects. Okay, then the most important is in case of severe. In severe, where the score is PYQ score is more than equal to 13, then we have to hospitalize the patient. We have to hospitalize. Okay, in severe cases we have to hospitalize the patients, and then we have to resuscitate the patients because of the severe dehydration. We have to give the IV fluids. Okay, we have to give the IV fluids. Plus electrolyte correction. Here in this case ondansetron can be given. Okay, but we usually, as this is a category B drug, so we usually avoid in the first trimester. Okay, so but in cases of severe cases, in severe PYQ score, we can give. Okay, we can give ondansetron. Maximum is 16 milligram per day. Okay, then corticosteroids can be given in case of refractory hyperemesis gravidarum. In cases of refractory, 100 milligram IVBD can be given, hydrocortisone. Okay, 100 hydrocortisone, 100 milligram BD, IVBD. Okay, can be given. Then low molecular weight heparin can be given if the patient is admitted for prolonged duration. For prolonged duration of admission, we give the injection low molecular weight heparin. Okay, but on discharge we can discontinue the LMWH. Okay, so what are the criteria for discharge? What are the discharge criteria? For the discharge criteria also, like the admission criteria, we have 4 criteria and all are required. Okay, for discharge also all the 4 criteria are required. First, ketones less than equal to 2 plus after 2 liter fluids. Heart rate should be less than equal to 100 beats per minute. Your urine output should be more than equal to 0.5 ml per kg per hour. Okay, then she must be tolerating at least 2 meals without vomiting. Without vomiting, she must be tolerating 2 meals. Okay, but so all the 4 criteria are required for the discharge. So these are the discharge criteria. What are the complications? The complications, these are rare but serious complications. So what are the complications? First, Wernicke's encephalopathy. Due to thiamine deficiency. Okay. Then Mallory Weiss rupture of the esophagus due to vomiting. Then splenic avulsion, this is also very rare. Then acute tubular necrosis because of the prolonged dehydration. Acute tubular necrosis. Then central pontine myelinosis, that is due to rapid correction of the sodium. And then we have to, after treatment, then we have to counsel the patient that hyperemesis, it does not have that much effect on the fetus. We have to reassure the patient and the family also and plan for discharge. So if any doubt, you can just comment below the video. Keep learning. Thank you.